Primum non nocere, first do no harm, is the title I choose because I firmly believe that by utilizing this notion, this principle, in the postmortem proceedings, we can reduce the emotional pain we could cause to the relatives of the deceased. So on the next slide, you will see my fellow group members. And I would mention that we are working on improving the postmortem procedure and the methods, the methodology of the postmortem procedures in order to include novel techniques such as autopsy. And we are working currently on two topics. The first one is about the diagnostic parameters of autopsy, and the second one is a prevention-oriented topic about the possible association between environment and parameters and the incidence of suicidal death cases. Our first topic is uncovered through a systematic review and meta-analysis. First, some thoughts about the background. I would like to mention the most important postmortem techniques, namely the external examination, which can uncover a lot of information about the deceased, however, is rarely used as a standalone technique. Secondly, I would like to tell about the autopsy, which is the most common way to uncover the cause of death. However, it causes changes to the remains of the deceased. The third and fourth one, as you can see, are histological and toxicological sampling, which are usually used for as a supportive technique. The fifth one, which I will elaborate a little bit later, are autopsy techniques. But why do we even need these postmortem techniques? Why do we need postmortem evaluation? Why can't we just bury the deceased? We need these to provide preventive programs with reliable statistical data on the cause of death, thus enabling them to save lives. We need them to find injuries and misconducts on the deceased, thus we can catch the bad guys. And we need it for quality control to give feedback to the medical professionals. However, the overuse of autopsy as the primary method of defining the cause of death, a lot of problems have arisen, such as there are several religions and cultures which prohibit the alteration of the body after death. And even if it's not prohibited, the alteration of the body, if the relative is aware of that, puts a huge psychological burden on them. Furthermore, autopsy requires a great deal of human and fiscal resources. And to propose a solution, we came up with autopsy, which can uncover the findings in a swift manner and a reliable manner without altering the human remains. Autopsy techniques include postmortem computed tomography, postmortem magnetic resonance imaging, and postmortem computed tomography with angiography. And to further prove the usefulness of these techniques, we posed the hypothesis that the diagnostic parameters of these techniques reach the gold standard of conventional autopsy. However, during our investigation, we found that in some cases, autopsy does not look like to behave as a gold standard, and the diagnostic capabilities of these autopsy techniques even surpasses the diagnostic capabilities of autopsy. Therefore, we pose the question that is conventional autopsy even a gold standard? And if it's not, can we make a statistically correct gold standard, a hypothetical gold standard? We conducted a systematic research and have been left with 102 eligible articles. The results are shown in the next slide, and as it's shown, the sensitivity is the y-axis and the false positive rate is the x-axis. And the better the diagnostic method is, the upper and left corner the closer it is to the upper and left corner. Therefore, CT in detecting respiratory diseases and skeletal injuries, MR in detecting neurological diseases, and cardiovascular diseases detected by CT angiography proved to have proper diagnostic parameters, while other parameters lagged behind. Yes. Furthermore, we evaluated whether conventional autopsy behaves as a gold standard, and we found, using AGES-ROC and Metatron R packages, that it is significantly different from a hypothetical gold standard. Therefore, we re-evaluated the diagnostic parameters of conventional autopsy and the virtopsy techniques afterwards, and we found that conventional autopsy is on par with autopsy in the case of cardiovascular diseases detected by PMCTA and detecting the cause of death by PMCT. Autopsy is still superior in detecting cardiovascular diseases than detecting it by PMCT. However, we also found that the detection of skeletal injuries and traumatic injuries and bleedings, as you can see, the dots are upper than the autopsy dots, are, in these cases, virtopsy is superior to conventional autopsy. To summarize our results, PMCT is the preferred modality in skeletal fractures and pulmonary diseases. As you can see here, there is a femoral fracture, skull fracture, pneumonia approved by the histological sampling. PMCTA can even replace autopsy in cardiovascular death cases. You can see the PMCTA recording with the occlusion, and it's proven on the autopsy, which was in this case unnecessary, carried out only for research purposes. And we can say that PMMR has a very specific role in acute hypoxic injuries. At the picture, you can see that PMMR can detect acute hypoxic injuries, and there is nothing to be seen on the autopsy room specimen. And as I said, autopsy cannot be accepted as a gold standard. We've submitted our results to European Radiology, which is a divan both in radiology and miscellaneous categories. Our second topic, as I mentioned before, is about the possible association between environmental parameters and suicidal death cases. Even though here in Hungary, the number of suicidal death cases is getting better and better every year. However, there is still 4.25 suicides every single day. And the available publications on these possible connections are often contradicting, and they lack decisive results. Therefore, we wanted to analyze our prospective registry on non-natural death cases, therefore they include suicidal death cases, and find associations with environmental, or in this case, meteorological parameters such as temperature, wind speed, precipitation, atmospheric pressure, humidity, and solar radiation. The hypothesis is therefore that when there is a sudden change, significant change in meteorological factor, it shows association with the incidence of suicidal death cases. And we believe that if we find this correlation, and we find that this correlation is strong enough, we can use it to more properly distribute targeted suicide hotline availability and psychiatric ward personnel availability in time. Our registry is a single center registry in the Semmelweis University Pathology and Forensic and Insurance Medicine Institute, and it contains all non-naturals and several natural death cases from 1899. However, we only have sustainable variables from 1987, and it includes more than 2,000 cases every year. In it, we found identified more than 17,000 suicidal cases between 1987 and 2020. We have all the most important data available for us, such as the date of birth, cause of death, time of death, and several other more or less important data. As I mentioned before, I've already submitted our first topic to a journal, and our second topic is in its very early stages, but we plan to submit it later this year. Additionally to conducting this research work, in the last 2 years I've held more than 150 undergraduate classes in forensic medicine. I gave several presentations in national and international conferences, and also completed my specialization to become a forensic pathologist. Thank you for your attention.
Congratulations. Do you think it will really replace the standard postmortem.
Yeah. Do you mind if I show a case about that? I have several other pictures, but I came up with this one. All right, so if there is a suicide by drug overdose, to answer it shortly, I don't think it will completely replace, but mostly it will replace. What happens now in Hungary is that there is an autopsy, before that there is an external examination, of course, and there is a toxicological sampling, and that's all. But do we really have to do the autopsy every time? If we check the body and there are no severe external injuries, the person wasn't beaten, then we can continue on. If the person was beaten, then we have to do some kind of autopsy to prove the misconduct. Then we can exclude most common natural death cases by postmortem radiology. And then we can do the toxicology testing. If someone has lethal levels of some kind of drug in their body, then I believe it's unnecessary. However, because of the Hungarian legislature, it is impossible to not do an autopsy. But in the later years, I think it's possible to change that. And I think autopsy should be a last-ditch attempt or last procedure to be chosen.
It's very exciting, however, it needs also a technical basis. So if you want to make a CT, I think it should be another CT than it's used in the general practice. So if it's there, it would be great not to make the real autopsy, because as you showed us, you can see the coronary arteries or you can see a hemorrhage. What about the financial background of all this?
Yes, all right. So there are, unfortunately, some superstitions. Like we have to clear the whole CT in a very high level or anything. But you can take these cadavers into 3 or 4 body bags. It wouldn't change the results. So I think that there is less cleaning needed after these kind of interventions than in a normal case. And because of these suspicions, radiology department tend to reject the idea of having these cases done in them. And I believe that if personnel is available, then these could be done like in the evening or midnight, so you don't have to interfere with the...
So this was my suggestion, as in the Middle Ages, when they did the autopsies in the night, in the cemetery, so you could do it in the night or in the evening, and then you are not interfering with it.
Yes, I hope if our article goes through, then it would propagate it a little bit, so we have something to show, and we can get on with it. It's a practice in the UK, they use it and so on, but unfortunately not here.
Is there any economic studies that it's really
not
cost effective?
Available.
Because the radiologist is also expensive, because somebody has to evaluate the pictures. For example, MMR or MR is also expensive. So I wonder if it's really will save some money and time.
Yes, so the NHS uses these techniques, and they had some research done, because basically they wouldn't use it if they haven't, but it's not available for anyone, because it's they spend money, they would like to use it like that. And also in the Hungarian financial system, it's hard to define the worth of some procedures. Because the hospital gets like 60,000 forints for an autopsy, for which if you do a proper autopsy, you spend at least 1 hour in the autopsy room. There is an autopsy technician also, and you work at least 1 hour on the computer with writing the report. So it's not really evenly paid for.
And all the histology you are doing,
yes,
and every other
and
procedures.
So it's hard to compare it in the Hungarian system, but like doing a PMCT angio scanning, the positive thing is that you don't have to really care about causing cancer to the patient or use the fluid in the angiology in a proper way, because you can use anything. You don't have to fear that the patient will have a kidney failure because they could not.
Or anaphylaxis.
Yes, yes. So you can use cheaper variants.
So as I know, in the university there are other groups who are making this cadaver imaging techniques, not for criminal things, but for general things with the placenta, with the lungs, and there are some projects in the Anatomy Institute and in our Biophysics Institute too. We have some cooperations. The typical problem is it's very time sensitive. So when you make this measurement and how you can fix it, or is it an idea to fix the?
No, it's only usable for people not under stage of putrefaction. You can find several things, but angiology is not available for them because the vessels break down and so on. So obviously it's not available. But most of the autopsies in the Hungarian system, at least like 60–70% of them came from hospitals. So there you have the chance to do it instantly. You don't have to wait anything. I knew about research groups who work in the anatomy department, but not on anybody about the clinical parts. And if you could connect us, I would be really happy.
In the clinical part, Kinga Karlinger did a very old, I think about 15 years ago.
Yes, I know about the earlier ones, but not something which is... And then there have been cases, like sporadic cases that have been uncovered, and also it has been used for victim identification, but not on a regular level, unfortunately.
Yes, and another question regarding to the first study, so about the statistics of that. So you showed us the sensitivity and the specificity pair. And there is another common pair, the positive predictive value and the negative predictive value. What is the difference and why it's typically showing this pair?
All right, so we also have results from the PPV and NPV values, and we also wanted to use them because if we get back a positive result, we want to be sure whether that's really a positive, and that's what PPV tells us. And, but the problem with that is that they are highly reliant on the prevalence of the disease, which is very different in our subgroups. So you cannot tell, so there are like respiratory diseases, pneumonia is very common, but like small cell lung cancer is much rare. So it's hard to differentiate like that. So we, as a supplement, gave several ideas of this subgrouping in the article, and included subgroups in the subgroups. So divided the subgroups by prevalence and looked for the PPV and NPV values there, so people can take those results and use them in their own practice if they feel like it.
Peter, firstly, this is a fascinating subject and it's a very difficult one, I'm sure. My question, I have two questions. The first is, now that the index test is a virtopsy and the reference test is autopsy, does this mean that in every eligible study in your meta-analysis, the same patient underwent both tests consecutively?
Yes.
Okay, and in this case, what about the risk of bias and the level of certainty of evidence assessments? Because this methodology could introduce some severe risks of bias, because something can be happening in blinding, something can be happening in allocation, and I didn't hear anything about the risk of bias and grade assessments.
We made the risk of bias assessment, and we found that most results are the grade assessment came up with low or very low reliability, because we wanted to take into account the type of observer, whether it's a radiologist, a forensic expert, or both of them, whether the person is a resident or have serious experience in the matter. But unfortunately, the data was not completely available. So in many cases, it was not available. And also, we found that, as I mentioned, the subgroups are very heterogeneous, unfortunately. But we have to work with what we have, right? So this is some kind of guideline we can provide, and obviously there are flows that can be assessed, but not at this level. There are some people who try to differentiate different observers to subgroups, and they found that it's better if, obviously it's much better if someone has more experience, and that they highlighted that people who do this, they should have high experience, because else the results are misleading.
Thank you for bringing us this topic. My question would be regarding the registry analysis. Could you tell us a little bit more about it? What kind of outcomes you are looking to investigate? Because I thought we briefed through it.
Yes, it is really brief because we concentrated on the other topic. I don't think we can jump to that. Maybe not. Yes. So basically what I didn't mention, but we worked on, is closing out confounding factors, and also to translate it after the registry analysis to some kind of, additionally make it into a meta-analysis also. So we can see our results and compare it to an international level, and then we can have everything we can get from this registry. And the hard part is really the confounding factors, because let's be real, most likely the effect of environment and parameters is not the most important one. There are social things having an effect on suicidal cases, like where people live, how much money do they make, is there high crime level there, or anything like that. We will try to focus on that because we know where people died and where they lived. But that's, once again, two very different things. So a person can die where they lived, but they can move to the other part of the country. So we have to be aware of that. This can affect the place they live, can affect their situation, and also the situation they got into when and where they died. So.
And for the meteorological parameters, is there an official database
Yes.
for each of the parameters, or do you have to look up
Yes.
each of them in different places?
No.
Just one?
They are, and there are a lot of places all around the country where they measure it, and they measure it properly, so that part is nice.